Hi, Rick Bukata coming to you, Risk Management Monthly, the November issue, November 22nd, Thanksgiving week. Rachel is on the line in Phoenix, and we have a special guest, Frank LoVecchio, who is with us also in Phoenix. And the three of us are going to talk about things related to medical toxicology primarily. Frank's specialty is medical toxicology, among other things. He's involved with the Banner system in which is a large system in Phoenix. He's involved with the county system there as well. He's involved with ASU, where he is sitting in his office now. And Frank and I've heard Frank's name for decades and decades and decades because of his involvement in emergency medicine. However, we've never met until I asked Frank, and I may have been on a cold call, if he'd participate in our boot camp course that we do in Las Vegas. And we were looking for a medical toxicologist, which brings up a really kind of sad note. You know, my good friend Jim Roberts died about maybe 3 months ago now, who was a medical toxicologist, among other things. His real claim to fame was this huge book he writes every 4 years called the Procedures in Emergency Medicine. So, Frank, welcome. Rachel, welcome. We've got some interesting stuff to talk about today that we've never really talked about, and which definitely has medical legal aspects. Rachel, I'd like to start off with something that you brought up a couple of days ago, which Frank is right in tune about regarding medical marijuana. Not medical marijuana, physicians smoking marijuana and the potential implications with regards to getting a job.
Sure. I'll open up with that. And then I'll also say the way that I met Frank was at ASAP. And I just think it's a funny story. So you and I were walking around ASAP and
yes, we were
just kind of schmoozing, and we got hungry and we spied these sandwiches, but they were on the other side of this glass cage. And we needed to get to them, but the only way to get to them was we had to listen to a speaker. So we decided it was worth it. So we kind of crept in halfway through this talk to get these sandwiches, and we sat in the back by the sandwiches and we're eating them, and we, begrudgingly started listening. And as we were listening, I leaned over to you and I was like, dang, this guy's really smart. Like, that's what I said to you. Like, who is this guy? He's really smart. And then I heard him say, I work in Phoenix. And I was like, that's weird. There's this really smart guy in Phoenix. I've never met him. I want to meet him. And so afterwards, since we missed the start of it, I didn't know who he was, but I knew this really smart guy who worked in Phoenix, and I wanted to meet him. And so we walked up there, and then one of my colleagues popped up on stage and clearly knew him. And she introduced us, and it was Frank. So
wow.
Small world, yes.
Small world.
Yeah.
Thank you so much, Rachel. I heard a lot about you too, obviously, because of your dad. I don't want to say I have your dad's job, but part of it. And also my residents go up to your place. They go up to Mayo.
Yeah. So anyway, small world. So
yep. And Dr. Bukata, I met a long time ago.
Oh, no.
He was a resident in New York City, Mount Sinai. We only had a couple of residencies in our whole, now you could throw a rock and hit 3 residencies in Manhattan. But it was one of the first residencies there. And after an ASAP talk, I went up to him and Dr. Hoffman and said, oh, hello, I'm a big fan, blah, blah, blah. So I was really, really excited to meet him. I used to have the cassettes, believe it or not.
That was very long time ago when we were in cassettes for sure.
Yeah.
Then it evolved to thumb drives and other things. And finally, we decided no more. It's going to be all on the internet. That was a while ago.
All right. So here's the dilemma.
I do want to acknowledge your dad because he was the dean at the University of Arizona. Was it ASU when the
ASU?
Yeah.
Arizona
ASU?
State. Yeah.
Because he was the dean at Mayo, and he kind of retired of sorts and came down to Arizona, where he took that job to get that medical school started. ASU hasn't had a medical school, which is kind of strange because it's a 35,000 student university without a medical school, and yet University of Arizona, which is down the street in Tucson, much smaller community for sure, had one for a long time. So let's get started with your story. Okay.
So here's kind of the conundrum or the issue that I raised. We'll call it hypothetical, but so there was an issue I became aware of where a physician, we can just simplify it actually, applied for we'll do a simplified version, applied for a job. And as part of that job, they did a drug screening test, and the test came back positive for marijuana. There was no language in the contract for the job that this was going to be an issue because in this particular state, marijuana is legal. And so the applicant didn't really curb their marijuana use because marijuana is legal. And test came back positive. Job offer was rescinded without any warning. And so physician had relied on this to move to that state, get a house, whatever, and job was rescinded without warning. Physician out of a job, has relied on this. Do they have any recourse?
Well, they didn't get the job yet, right? So you can't kind of get an employment sort of attorney. The testing is really, really tricky. I mean, so what? He had a urine drug screen, I assume, positive for marijuana. Mm-hmm. It suggests that you could say with certainty probably used in the last 72 hours. Okay. And, it's a little trickier too. It might be a little bit longer if you take edibles, but if you smoke, one time, one puff or two, you'll likely be positive for about 72 hours. That's what we could say. We can't say that he's high. We can't say that he was high during the time. And most of the time, you're high maybe 2-3 hours or so, usually peak within an hour. But that's a difficulty, right? Hospitals don't want to get into the business of saying you're intoxicated, you're not intoxicated. They just want to say you're positive, end of conversation,
And his argument is, yeah, I used because it's legal and nobody ever told me I shouldn't. If I would have been told, I wouldn't have used.
Yeah, it's a tough one. I think we mentioned earlier too, that we do it to our residents. Our residents go through the whole application, they get accepted and the match, then they have to get fingerprinted and then do a drug screen. But they are kind of warned, at least, I don't know if it's in writing, but certainly everybody tells them, we check for everything, including marijuana. And if you're positive, you can't get a job here, which is pretty traumatizing if they lost a job.
Mm-hmm.
So the washout period is something like 3 or 4 days. And so it'd be best if you don't smoke for a week. Well, would that be a safe thing to say?
Yes, it would be. You see studies or you see reports where people are positive for like 28 days. That is the rare exception. That's a very, very heavy Rastafarian type who smokes multiple marijuana cigarettes, multiple joints per day. If you have a lot of fat on you and you smoke every day, you could be positive for up to 2 weeks or so. Ooh. So you got to be careful. But if you're just a casual user, hypothetically, people have said to me, I'm getting a drug test on Monday morning or Monday at noon, and I use Thursday night. Will I be positive? And I say no. And they say, well, what should I do? I say, just to be cautious, you should drink lots of fluids. They go, wow, I looked down on Amazon. There's this great kit to help me beat it, to help me beat the test. All of those tests tell you, take this one pill, it might be vitamin C or placebo, and drink 4 gallons of water. Or, it'll have caffeine in it, so it's like a diuretic, or very, very low dose like Lasix or something like that. So, you don't want to be too dilute. You don't want to be too dilute, especially the day of, because then they'll reject your test. But lots of fluids beforehand. I'm not telling you how to beat drug tests, but hypothetically, if you were asking me, that's what I would tell you.
So this particular physician, in the language for this job, there was no language about marijuana specifically, that was testing for illegal drugs. So I think it was outdated language because it was presumably written at a time when marijuana was widely illegal and now it's not. And so, he had relied on the language to quit his old job, move across the country, put an offer on a house, leave his old apartment and, had done all of these steps, presuming that he had this job. And then he lost it. And so, it makes you wonder legally if there's, some legal responsibility from this new employer for not giving him a heads up that actually we are going to punish you for using a legal substance, because how is it different from alcohol in that sense? And that when you use it, you're only intoxicated for a couple of hours, but we've made a moral or ethical decision that we don't like it.
Mhm.
And so we are going to then take away your job for using it. It's hard for me to distinguish those two. And so if you're not giving him a heads up that that job could be lost, I don't know. It's very.
I think the
it's
argument
hard
is
for me
that
to
it's
distinguish.
federally illegal, right, Rachel? So if it's federally illegal, then people argue that. Of course, I'm with you. Look, I don't think it should be illegal. He shouldn't lose his job for that. But the test right now, you can't differentiate whether he smoked 1 minute ago or 10 minutes ago or 3
Mhm.
days ago. So they're just like, hey, we don't want to get into that business. Screw it. We're just going to say you're positive and you're perhaps intoxicated right now. And we're going to say, no go. They do check for alcohol in the urine drug screen typically. And if I have a drink 12 hours later, it'll be negative on the urine drug screen for the spot one. They could do these
Mhm.
other tests that are more extensive, that sort of stuff. I know what you're saying, and I sympathize with them. I don't know. Any good
But they're
answer?
not, yeah. But they're not administering the tests before they show up to work. So it's kind of, yeah. Anyway, just I think that, there has to probably be some requirement by these employers that the language is updated to make it very clear on if they have zero tolerance for marijuana or not, so that people that are in these states where it's legal understand what their obligation is to their employer and don't get themselves in that situation.
They check for opiates, right? So all of a sudden they check for opiates and your opiate screen is positive, and then you show them a prescription for OxyContin for your chronic back pain that you take, 2 or 3 times a day. They would probably let you work. That's the irony, right?
Yeah.
Yeah, it seems that there were damages, but there were not probably enough damages so that it's worth pursuing a lawyer and all that other stuff. But substantial costs were incurred in this. Plus, I'm sure there was a lot of emotional distress and loss of consortium during this, which is probably worth a lot of money.
Yeah, I mean, that's a big dice to roll to go after a big employer. Unlikely that you're going to win that one and get a job later.
Right, I agree, absolutely. Yeah. You're compounding your problem. It's like best to just kind of say, okay, rather than and this doctor then sued the hospital, and he's going to lose, or she's going to lose,
right? But I think bottom line for physicians have to understand that just because it's legal in a state doesn't mean you have the right to use.
But I agree. You need to play the game fairly and tell the people that that's the rules you're going to play by.
Now, what about moving on from that? So let's say you don't have a drug test pending. Let's say you're just a physician that is employed and you don't have a shift coming up for a few days and you're just at a party. Weed is legal. Weed is not legal. But you're at a party with a bunch of weed. Let's start with weed is legal in your state.
And you use it, right?
Yeah.
So most states you're not going to get arrested in, right? Why would you? But does your contract say you're not allowed to use it? And if your contract says you're not allowed to use it, then I think you shouldn't use it. But if you go back to work a couple of days later and you're positive, I think you're in trouble, unfortunately, because it follows like the federal standard. I'm not for this. Don't misinterpret me. If you wanted to say to me, is there a test we can do for alcohol? First, if you're impaired, 0.08 is impaired in most states, right? We call it 80 milligrams per deciliter for alcohol, or 0.08, is what the cops say. If I smoke marijuana right now, you could check delta 9 THC, and that usually peaks really, really quickly. And usually your level is under 2 nanograms per ml 4 to 6 hours afterwards. So if it happened to me, God forbid, I would say, I'm not taking the urine test, I'll do a blood test. Or, I want this to correlate with it. And, your hope is that it'll be under 2 nanograms per ml. So you can put it behind you. You can say, look, I did this more than 6 hours ago, and here I am at work. Of course I'm sober now. That's me giving legal advice, which I shouldn't do, right? I mean, I think it bows.
No, this is good. This is good. So urine test doesn't give you any objective values. It's just going to get you in trouble. Blood test gives you a chance of saying, I'm under this limit, which should not be intoxicating.
Mhm.
Okay.
Even
All right.
better, your delta 9 THC, you check for these metabolites, will be
Mhm.
0. Then you could say, yeah, I'm positive these non-intoxicating metabolites, but I did it way over 6 hours ago.
All
So
right.
what? In the old days, it used to be I went to Amsterdam for the weekend and then I tested positive. Now it's wherever, most
Yeah.
states. The tide is turning. I always thought that this administration was going to make it federally legal and it was going to be a lot easier. But what we tell people is, well, you can't get a DA license now because you tested positive. And if you can't get a DA license, then you can't really practice at our institution, which really, for lack of a better word, sucks.
Yeah.
Yes. So we don't have any solutions except don't know the rules. Don't smoke before you're tested.
Are you seeing contracts that have express language about marijuana use in them?
Ours, I'm told that ours has it because some of my colleagues who are gonna, obviously, Phoenix is like a big shuffleboard with people moving all around. They said, hey, we're gonna come work for you. And then they told me about it. And they said, hey, I've used marijuana. And I did tell them to do that. I said, that's your decision, etc. But you have to wash out, wait for at least 3 days. He says, well, I use every day. I said, all right, try to extend 5 days, drink lots of fluids, etc. And if you drink too much fluids, your urine's going to be very dilute, and then you're going to be considered, quote, positive. So people are usually told, drink lots of fluids, maybe with caffeine, it'll cause this diuretic effect. And then maybe the day of the test, kind of just hydrate with like Gatorade, which will, kind of bring your specific gravity up again. Okay. Maybe not where we wanted to go with this talk, but I'll also tell you some cool ones that I've seen. One of my favorite parts of my job is doing legal stuff. And I love it because you learn something new every time. And so you have a guy, who maybe works for, we'll say like a trucking company or something like that. And he tests positive for marijuana. And he says, hey, this is not on me. I went into a shop and it said CBD, and I've been applying CBD to my joints forever. True story. It's almost impossible to get CBD non-pharmaceutical, like if you just go buy it at one of these million shops that have signs up, that does not have THC in it. So another rule is, don't use CBD, don't use hemp oil, don't use CBD, because that will show up positive. Unless you buy from, Merck or Pfizer that tells you it's 100% CBD, it's going to show up as a small trace of THC.
Huh.
Really good advice.
Yeah.
So, are there any more issues related to marijuana that may have some medical legal consequences that we ought to know about?
What do you think, Rachel? Do you think it's like worth talking about some of the medical stuff, like the hyperemesis syndrome that we see? When people use marijuana in the past, I never used to see this hyperemesis stuff. And now it just seems, I don't know if it's more potent and that's why, but we just see people have this rip-roaring vomiting, etc. And it's hard to convince people that it's related to their marijuana because this hyperemesis syndrome usually happens, at least a month after. They might have been using it for, months to years. And I don't know the right way to treat it. I know there's case series where they do all of these weird things, sometimes even, apply stuff to their belly, they give them antipsychotics sometimes and they stop vomiting. But it's one of those things, maybe working at a county hospital where I could spot across the room. You hear that retching, like, the devil has got them. And it's like, they're like screaming and vomiting. And you're just like, okay, that's got to be, hyperemesis syndrome induced by marijuana. But I don't know if you got an approach to it. Do you have a good approach or a good feel of how to treat it?
We see a lot of it. I don't know if we see it, the folks frequently enough, for this chronic problem, enough to know how successfully we're managing it. We do a lot of droperidol in our shop, which tends to work acutely more successfully than most other things that we use. So that's probably my personal go-to, but yeah, I don't know. Do you have a personal preference?
When I was the director of the Poison Center here, we used to tell people to take a shower, and I thought that was ridiculous.
Oh yeah, hot packs and such. Yeah,
there's something about the vasodilatation, and maybe it's the droperidol. causing a little bit of vasodilatation because of the alpha effect, or Haldol, et cetera, causing that. So I don't quite understand it. But I
Usually
think,
go ahead.
no, I think the teaching point is, you got to tell people not to use it anymore, unfortunately, which really bums them out. And
Yeah. And, our GI folks, they usually come in wanting to see GI. That's why they've made it up to, North Phoenix, Scottsdale, because they're seeking a GI specialist appointment. And our GI folks won't see them unless they're 3 months of cessation, because,
wow.
And so that's what we're preaching to them. Like, unless you've been off of it for 3 full months, you will not be seen by a specialist. And that's essentially a stop for them, a full stop. And then by that point, they don't need them, which is essentially why GI draws the line at 3 months for them. And by the time they've seen us, they, one of the ways that we kind of confirm what's going on is they tell us, yeah, our hot water is out in our house, because they've just been living in the shower that long.
Good stuff.
Yeah.
Or in Phoenix, you can just go outside in the summer, just lay on the ground. It's probably the same effect.
Yeah.
Shall we move on to another issue that may have some medical legal applicability? Do you want to do opioids?
Sure. I think we should talk a little bit about it. And I think the opiate of the day is fentanyl, right? I think fentanyl is, of all the drugs of abuse, and, whether intentional or non-intentional overdose in the US, opiates is the #1 killer. And of the opiates, fentanyl is the #1 killer in that opiate group. So I used to think, that the pandemic would eliminate all people overdosing, et cetera, because most drugs are smuggled over across the border. And actually, we've seen a surge of deaths, and we've seen a surge of opiate use. So it's kind of had the opposite effect. But I think the medical legal aspects of fentanyl use is what to do with the patients after they get Narcan. And I don't know about where you guys live, but many times people are found down, the classic opiate triage, decreased respirations, pinpoint pupils, altered mental status. The most important one, which we don't always mention, is response to Narcan, because other things can give you that scenario and not respond to Narcan, but they respond to Narcan, they wake up a little bit. And, how long do you keep them around? And I think it's really a tough question. When it first came out, we used to keep people around for a day. That's what we used to recommend at the Poison Center. Then it evolved into 12 hours. Now it's evolved into 6 hours, see how they're doing, unless they look great. Because the fentanyl pill, no one takes a fentanyl pill by mouth. And, they have a 30 on them, M30s. And the reason why they have an M30 on it is they're supposed to mimic OxyContin 30 milligrams. And to mimic that, you need to put lots and lots of fentanyl on, sometimes, 3,000 micrograms. So think about it. If you have somebody with rip-roaring abdominal pain or a fracture, you might give them 1,000 mics. This is like many, many fold higher than that. And the reason why they do that is because it's not bioavailable really that well if you take it orally. So it's meant to be taken by mouth. The drug dealer should tell people that a little bit better. You shouldn't be smoking this. You shouldn't be shooting it up. And when they shoot it up, think about it. It's not like you give them 100 mics by accident, the patient's altered in your emergency department. They're taking 3,000 or 5,000 or so. And sometimes they're putting more than one tablet in. And it's unfortunate, but you can crush those pills and mix it with a little bit of saline is preferred as opposed to water. And you'll get the effect of fentanyl, similar to heroin instantaneously. By the time you finish pushing the needle in, you'll have fentanyl in your brain. And that's what most addicts want. Addicts are like the emergency physicians of the world. Immediate gratification is too late. We want it instantly. We want to, feel good right away. And I don't know how long to watch them. My colleagues push for shorter and shorter. I push for a little bit longer. I always put a script of Narcan in their hand, whether they fill it or not. I don't know. I always try to suggest that they get detox. And if they're in withdrawal, I think the big push is to push buprenorphine or Suboxone.
So,
sorry, a lot of words there. Sorry.
With the fentanyl, why is it different than the fentanyl we have that wears off within an hour or two?
Yeah, I think the short answer is yes. The longer answer is why. And it's like, if you had a patient and you gave them 50 of fentanyl and they were altered, and then you shook them 15 minutes later and they're awake, you'd say, okay, you can go home, right? But what if I told you instead of 50, you gave them 5,000 and they were altered? You'd say, okay, that's going to last a little bit longer. It's kind of a dose response thing. Yeah. And it's not uncommon for these people who have habits of 10 of those tablets a day. They're very, very cheap. And then I don't want to say frustrates me, but one of the things that's tough is, when you say, what's the half-life of Narcan? I know I'm going to get yelled at and get some hate mail for this. The half-life of Narcan is variable. It's like, say, 30 minutes to an hour, give or take. That's the study with 0.04, milligrams. Mm-hmm. But isn't it going to last longer if you give 2 milligrams? Is it going to last longer when you give 10 milligrams? And some of our patients get 2 in the arm, 2 in this arm, 2 nasally, and then they finally get an IV and they'll give another 2. Well, that's kind of a different patient. Can you still say the half-life is 30 minutes? I don't know. The study suggests no, right? It kind of says higher dose, it lasts a little bit longer. And that's why I try to keep them longer. So if I was king for a day, I would recommend that you give them the smallest amount of Narcan possible, just to wake up a little bit, breathe a little bit, and then keep them till 5 half-lives of that Narcan is gone. Okay. And you got to add a little time if it's more than, 0.04 or 0.08.
Yeah. So we have a boot camp that we run for the 4th year med students, where we have a patient that we kind of accidentally wake up to abruptly with Narcan. That's an overdose patient. We wake them up to abruptly, and then they want to leave. And when we do this, the med students are, really uncomfortable with the patient leaving. We basically, it's a simulation. So we have the patient walks out, and the students are all like really freaked out because they recognize this is a really high risk patient. They want to stop them, but obviously they're not going to like tackle the simulation patient. And I talked to him about, and what I end up saying to them is, this is totally realistic. And also this is kind of what you have to do, because in this scenario, yes, it's a high risk patient, but ultimately now you've created this patient that has capacity because you've woken them up to the point that they are no longer sedated or impaired, and they do have decision-making capacity, and you can't stop them now. And so I, encourage them. We kind of review the elements of decision-making capacity, and I encourage the patients or the students to kind of go through that to the best of their ability with this agitated patient who's now wanting to leave. And if they happen to do that, the patient will kind of cooperate with them, but ultimately leave. And I think that's pretty realistic with these patients. If they're cooperative to the point that they answer those questions, they do have capacity, and they're just going to go. And I think when you wake them up to that point, that's what these patients are going to do, right? Because now they're withdrawing and they want to go. And so I agree with you. If you can kind of control the situation with modest amounts of Narcan to the point that they're breathing, but not uncomfortable, that's ideal. Keep them safe, but not agitated. That would be great. But if you get them to that point where they're uncomfortable, they're going to walk out. And medically, a lot of the times they're young, healthy people, but there's not enough else going on. And then they do want to go home, and there's really nothing you can do to stop them legally. And so you create a situation where you're sending a patient out to probably do more harm to themselves. And that's really unfortunate, but also realistic.
You have a checklist, like if someone's going to go AMA, like let's say they're a little drunk or a little inebriated or a little intoxicated, and you say, if they can do these things for me, then I think that they're not intoxicated or inebriated, or they're safe to sign an AMA.
For capacity? Yeah,
capacity.
So I do. There's like 4 elements of capacity. Do they understand their character? Do they appreciate the risks? Are they able to communicate their reasoning? Yeah, I have it. And I kind of pull it up almost every time I go through it, because it's not very intuitive to me. And I want to be really careful that I am documenting it every single time. And I put it in my documentation every single time. And I give lectures on this, and I still, to this day, like it's so non-intuitive that I pull it up, I Google it every single time, like 4 elements of capacity, and I'm like on my phone, like, yep, okay. And I still do it like that for these patients because they're so high risk, and I want to make sure that I've done it. So I do it for these patients, I'll do it for the drunk patients, and those rare patients in between where they're making terrible decisions, but I can't stop them.
So you do the same for alcohol, et cetera. It doesn't really matter what's impairing you.
Right.
I mean, because that's the fear, right? They kind of go out and do something stupid, do drugs again, or get hit by a car, and then you're kind of on the hook.
Yep. And there's just so many times where, that's all you have to do. And like elderly patients, for example, that are just, they make terrible decisions a lot. And really you just have to demonstrate that they might just have a UTI and they're refusing admission, and like they're kind of on the fence of being weak or something. And you're like, gosh, there's a really good chance they're going to fall and break their hip. But I think they have capacity. They think they have capacity. But if you're documenting, that you at least tried and you took the steps, you took the time, and you document it, I think that's very protective, in all of those scenarios. So I, chart that, and it really doesn't take that much time, but it's very rarely charted.
Do you like ask the nurses like what they're charting? I've learned that the hard way, and by doing some of these legal cases, I've always asked the nurses, it's like, okay, what are you going to write about this? I don't try to influence them, but I say, I'm going to write that I usually have a witness. Okay.
Yes.
And try to say, okay, we're on the same page here. You understand what's going on. You could repeat to me, like you could die and something bad could happen, etc.
Well, for conversations like that, I would have the nurse in the room with me so that it's, I don't have to ask after the fact, like, what did you write? It's just like, we're all in the same room.
Right.
Yeah.
That's what I mean. Yeah. Have them in the same room so you could make sure you're writing the same stuff. Do you ever put them in an Uber? You let them do whatever they want? Can they walk out of your emergency department if they're low?
Like drunk people?
Yeah, they're drunk, but feel like
we
they have
almost
capacity.
We almost always are getting them a ride somewhere safe, especially because we're pretty isolated. If you're walking out, you're in the desert. There's nothing around us.
Yeah, unfortunately, we're by a train, by traffic, and it's just very worrisome. And they might.
Yeah, no, we definitely pay to get them to a destination, but we also, that's easy for me to say because have more resources than I think a lot of emergency departments.
Yeah, I think it's easy to ask when this person gets injured and they left the emergency department and somebody needs to pay, did they really have capacity? And so your checklist would be really helpful. But then the other issue is, have you really advised them of the risk of leaving so that in fact that they really understand the potentially worse things that can happen to them? Because I think if they have capacity and you say, listen, there's the chance that you're leaving with this chest pain that you could have an arrhythmia and drop dead. I think that's important that they know the potential consequences, because they might say, well, I didn't know I could drop dead. I just thought I had a heart attack, and they don't know necessarily connect the dots about the potential consequences of leaving. So I do think there's clearly a risk, because you hear of these cases where people leave and the other thing that relates to that is when they're leaving and they've just basically eloped. And kind of what would be a reasonable thing to do for somebody who has eloped, who you're concerned about with regards to mental capacity. And I think that, people are going to say, well, what did you do? I mean, so we called the hospital security. Okay. We looked around the grounds. Well, did you call the police department to advise that there's a patient out there who is potentially in danger? And I think that you have to go through the whole process, because they're going to say, well, what would a reasonable person have done in this case? You were very concerned about this patient, and yet you didn't really kind of follow through to what others would think to be a reasonable thing to do.
Do you think it's reasonable to call the police on these cases, like the local police, and say, hey, we got a patient that kind of absconded?
Absolutely. They can at least help you try to find them. They have more manpower than you do. They could cruise the streets around there, so that just reasonable things are done, because we've all heard of these cases where people go out and get hit by a bus or something, like, something bad happens to them very close to when they left the hospital. And it's kind of like, are you culpable? And I think you have to be really careful when these things happen. And I agree fully that there ought to be members of the nursing staff there. I think there ought to be members of the family there, so that everybody's in agreement that Frank left and he knew what the potential consequences were. I don't know why I said Frank, but it's.
I would never sign out against you, right?
So, any other issues with regard to opiates? Because I personally would like to talk a little bit about the buprenorphine business here, because I kind of think that virtually all emergency departments with their, of any size should really have a buprenorphine program in conjunction with members of the medical staff who are willing to see patients who have this problem. And I think there are always members of the medical staff who are willing to help. These people invariably have some form of insurance, medicated at the worst. And I think that it's kind of one of those things where the question is, why didn't you have a program? I mean, all it requires is that the ER folks do this and that, and that certain primary care doctors agree to see them within a short time of their emergency department visit. And is that so difficult to achieve? So
it's tricky,
I think that's reasonable.
Yeah, I agree. But I don't know why a lot of emergency physicians are very, very reluctant to do that. They don't feel comfortable. It's just, I think maybe it's an education gap. If you give somebody Suboxone, if I got you out of withdrawal and it required 6 milligrams Suboxone, and it's the middle of the day, I'm so confident that I could give you another 6 milligrams in your hand and say, tonight, when you start to feel withdrawal again, take this. And then tomorrow morning, you can see, one of our outpatient doctors. That's an ideal world. But of course, that the potential that they walk outside and take all 6 milligrams at once, and still nothing's going to happen. When I say nothing, almost nothing is going to happen, because they reach kind of this ceiling effect. I mean, it's magical. When this drug first came out, I said, this is not going to, bear the test of time. It's just too good to be true, where if you take 6 milligrams and that gets you out of withdrawal, and that's perfect. If you take another 6, it doesn't make you higher, I mean, you do get intoxicated if you just take the drug a little bit. Obviously, it's a pain reliever. And when we mix it with Suboxone, it's buprenorphine and an antagonist. So if you inject it somehow, it would cause you to go into the Q withdrawal. The joke is you'd only ever do that once, because it'd be the worst withdrawal of your life. So I think we should. And I think the big barrier is maybe some knowledge of this whole, drug, and a better understanding of it. They don't rely on these patients. They feel uncomfortable with them. A lot of it gets diverted. If you write it to a pharmacy, sometimes they sell it on the street.
Well, even if they do sell it, it's good for them to sell it on the street, because it'll do the same thing for their colleague addicts. I mean, I've heard people say, well, they're going to sell it. And I've heard it's like, well, so what? It may be doing some good if they do that, because it will not exceed a certain level of brain capacity involvement. So I think that this is an evolution of emergency medicine. I mean, Suboxone and buprenorphine were really not something that we were familiar with like 10 years ago, but it is now. And I think that it's kind of like we need to evolve with the science. And I think that these folks are in serious trouble. And if we can help them by seeing them in the emergency department, acknowledging that they had a near life threatening or ending, maybe that'll give them the heebie-jeebies a little bit about continuing. Maybe not, though. And if you can say, okay, well, we have this other treatment that was not available in the past, I think I don't think it's hard to do this. And I think that the initiation has to come from emergency physicians. It's not going to come from anybody else in the hospital. It needs to be an emergency medicine initiated endeavor. And I think that, Rachel, are you familiar with hospitals doing this?
Yeah, I think one criticism I've heard that I don't know if I've heard a good answer for is the concern that if this becomes initiated in the emergency department and we don't have a place for people to have this continued, is that people are going to continue to return to the emergency department for their, refills of the prescriptions. And then that's going to be the solution. And that we're already kind of becoming primary care for everybody else. And so what's the answer for that?
Well, I would ask, I don't think you can really give this stuff out without some reasonable follow-up expected. I mean, it's kind of like you're only kind of, we're not necessarily able to prescribe it unless you've got an X waiver. They've made getting X waiver a pain in the butt. I think ASAP is really trying to.
I mean, it's not hard to prescribe this now. They've kind of relaxed those. We could prescribe for additional days now. So they made it easier for us to prescribe. And there really isn't there aren't a ton of places that are going to pick up these patients. So it's easier for us, but where are these patients going to go now?
Rachel, in our city, there's dozens, there's a group that gets Medicare funding and government funding. And they guarantee from the, I guess, CEO, chief medical officer's mouth that they will see anybody that walks in that day. So we usually try to tell them to go, in the morning, the next morning. There are a lot of places, and I don't know, Arizona's maybe not as progressive as some other states. I imagine other states have this too, where you can kind of go and get, not necessarily Suboxone. Sometimes they put them on methadone, which is a whole other topic, but they usually can get resources. I mean, there's a lot of federal money that's.
Yeah, I was going to mention that too. There is a lot of money, and so it's just a matter of, I think, or not that it's all that easy, but connecting these resources so that in fact you now have a program.
Yeah. And not so much locally, but just going to some of these talks at ASAP. That was some of the concern that folks were raising in the audience is. If we do this, we don't want these patients coming back, I
think you were talking earlier about giving somebody Narcan and they start to go into withdrawal. And I think that's one of the if you give buprenorphine and they're not in withdrawal, you can kind of precipitate withdrawal. So they wouldn't like that. But there's kind of easy protocols, I think, that you can follow where you just kind of do a withdrawal scale. And if it's greater than this number, you can do it.
Right.
And sometimes you got to wait or you tell them to come back the next morning or something like that. Maybe not in your ED. But I always say this to people, when they give too much Narcan, the guy's up and withdrawing, and then he wants to leave against medical advice. And then the guy's a jerk because he wants to leave against medical advice. I usually say to them, hey, did you get COVID or the flu this year? How'd you feel? And they're like, they usually say, I felt like crap. And they give all of these things. I go, picture your worst day of COVID. And all you had to do is walk, 100 yards from our hospital and take one pill and all of that would go away. You would do it, of course, right? You would do anything to kind of relieve all of those bad symptoms. Yeah. That's why I think it really comes to play. I mean, I know nobody dies of opioid withdrawal. That's a general kind of consensus that you don't die from the withdrawal, but you're going to feel like you're going to die. And there's an easy treatment where they could just go back on the opiate, which we don't want. We want to put them on something else that's a little bit safer.
Yeah.
When you do the drug screen on those folks, I think we didn't really, about the opiate thing. A lot of hospitals don't have fentanyl in their urine drug screen. Okay. And they might get a false sense of security and, that they didn't use opiates or whatever. And then the other thing is that sometimes they use methadone. Okay. And I always try to be very, very careful with methadone because it lasts so long. So if I overdosed on methadone, somebody gave me methadone, and you did a urine drug screen that was positive for methadone, you're obliged to watch them even longer because it kind of could come back, the respiratory depression, stuff like that. But I say be careful. I don't know if you check urine drug screens on all these guys or just kind of follow clinically. Do you guys do that?
It's variable. We don't have a standardized practice. We
Go ahead.
Yeah, go ahead. That's okay.
Speaking of measuring, could I just go back to the alcohol business? Because I think one of the things that you wanted to talk about, and I agree, is what's the utility of doing a blood alcohol in a patient who's clinically intoxicated? Would you go through a little bit of that?
You want to go first, Rachel? It's kind of this is so controversial, but say what you do.
All right, sure. I'll do mine, and then you can do the expert critique.
No, not at all. I don't. You're the expert. I
No.
think a lot of it is a legal question, right?
Yeah, I think it is.
Yeah.
So let's see.
Rachel,
I'm trying to decide.
That was a yes or no question. Wasn't that
No, I don't think there's a right or wrong answer here. I sure don't get blood alcohol levels in most of my patients. Let's see. I think that if a patient is really altered,
Mhm.
And it's unclear that it's all alcohol, that there is a role for blood alcohol testing, in like severely altered patients.
Okay.
I often get it in those patients. If a patient is just slightly intoxicated and they're brought in for something else and you're just expecting them to kind of clear up, or you're not really concerned about their level of intoxication, I generally don't get blood alcohol levels in those patients. I'm really not worried about their intoxication. And then there are some patients that are in between where I'm kind of expecting them to clear. And if they do clear up as anticipated, then I don't get alcohol levels in them. If I'm expecting them to clear and then they start getting more confused for some reason and, change in a way I'm not anticipating, then I may get a level in them because they're not clinically behaving in the way I was anticipating. So that's kind of how I play that.
So if it's a guy or woman who, family members say they were drinking alcohol, that's all, and they look intoxicated and they're a little altered, maybe it sounds like you wouldn't. There's no signs of trauma, right?
Right. And if they came in for that, I'm not even sure why they're there. Yeah. I mean, yeah. If they get so let's say they came in, they're drinking alcohol and they came in because they cut their hand, and I deal with their hand cut, and then I don't care about the alcohol intoxication.
Right.
If they brought them in because they're drinking alcohol and they look like they were drinking alcohol and their family member is worried because they're a little drunk, then I just let them sleep for a little bit until they look a little more sober, like I'd expect. Yes. Then I don't care what their alcohol level is. I would not check it.
And then if there's signs of trauma, maybe you check or no? They bang their head, they're a little altered.
No, not necessarily. I mean, if they are acting like I would expect otherwise, no. If they bang their head and they're drunk, I'd scan their head.
Yeah, scan their head. And then some people say you scan their head, you scan their neck. I don't know. It gets so.
Yeah, I would follow the imaging rules for that.
Yeah.
I'm a big proponent of ASEP's imaging rules. I
didn't know that there were imaging rules.
ASEP has what they've basically taken the Canadian head CT and C-spine and Nexus and combined them all into level A and level B imaging recommendations. And they're nice because they've taken all those and put them together. And the level A are ones where if they've had loss of consciousness or amnesia, and the level B is without loss of consciousness or amnesia. So they have them for both sets of patients. And that's actually what CMS looks at for their recommendations that are tied to payment rules. So it's nice because they've taken kind of all the evidence-based guidelines and put them together.
Man, I was totally not aware of that at all. And I wonder how many of our colleagues are aware, especially when you get into the situation where you don't follow them and they say, well, are you a member of ASEP? Do you acknowledge that this is a highly regarded professional organization? And are you aware of the guidelines that they have for the treatment? And you say, yes, I am a member, and I guess I know I'm not. And I think that that's a place where guidelines can potentially get you in trouble, especially if they're not written carefully, where in fact they become rules. Canadians are really good on, the ACA rules, the head rules. They like the word rules, which is not generally what you think of Canadians. Canadians are nice people. They're very agreeable people. They don't mandate anything up there.
Well, those ones are nice, but
Guidelines.
those ones were only like validated with patients that lost consciousness or were amnestic to the event. And that's not the majority of patients. So they actually don't apply to most patients that you're looking at, which is what, when people are applying them like residents and stuff, they're pulling up Canadian head CT and they actually are not relevant to the patient sitting in front of you. So it's actually ACEP level B recommendations that they should be looking at.
Wow.
Wow.
There was a talk at ACEP a couple of years ago. It was called, I'm paraphrasing, of course. It said, are you reading the guidelines? And it said, lawyers are, and it's kind of like the first thing they Google when there's like a legal case that pops up and say, hey, do you follow these guidelines? Do you trust them, et cetera?
Yeah.
Yeah. I think there's like some cool studies where they like kind of asked physicians, is this patient intoxicated? And they were pretty good, like in the setting of blunt trauma, but it was pretty inaccurate with the fact of them trying to identify sober patients. They considered sober to be under 80 milligrams per deciliter or 0.08, which is what the cops do. And they were only right like about a third of the time, 32% of the time, to say if they're, quote, sober. I think that's kind of interesting. Now, granted, it was a setting of blunt trauma, but they said there wasn't head injury, that kind of stuff. I don't know. I could argue both ways. Sometimes I like when my residents say they're going to get an alcohol level, because I could say, well, what if you don't? And if they don't get an alcohol level, I say, hey, what are your considerations for getting it? I think there's pros and cons and great variability. One of the big arguments against it is all of a sudden his alcohol level is 400 or 0.4. Then you're kind of bound to watch him for how long? Till he becomes, quote, legally, sober, or till the level 0. Because
Actually, that's what one of the things I think, Rachel touched on the use of blood alcohols in the clinical setting when you're trying to make a decision whether this person is solely intoxicated or there is some other thing going on as well. But the other part of this relates to when you may be able to discharge a patient. And I've really had strong views that one of the reasons not to get a blood alcohol is because we know of the straight line metabolism of this stuff, so that you more or less will know what the blood alcohol is when they leave the emergency department, and then they go out and then they get hit by a bus and their blood alcohol was X, and people could say, well, they were still under the influence of this drug. And I think that when you talk about 0.08, I think it's really related to the ability to drive a car. Mm-hmm. It's very specifically limited to the ability to drive a car. But there are people who have 0.08 who are more than have total capacity. I mean, they are clinically pretty much okay, even though the number is 0.08. So I think that they had to draw a line someplace, and they've lowered the line. In most states to 0.08, but it used to be higher. And so it's kind of like, in some ways it's kind of arbitrary, but in our business, letting people go who are intoxicated, I think having done a blood alcohol just because they're intoxicated is kind of like, I don't think it's a good thing to do. Mm-hmm. I think you should do it only in the setting where it's clinically necessary, because you're concerned of the potential, the reasonable potential of something else being there. Because I want to let people go who are intoxicated, who were intoxicated, because I've made a clinical assessment that they are okay to go. Their speech is clear, and you've written a paragraph or a part of a paragraph that makes it clear that you believe that they have the capacity to leave and that they are not a toxic when they walk in, those kinds of things. So you paint a picture of somebody who is okay to go, or get picked up by their brother and taken home, those kinds of things.
So in that case, if you got an alcohol level and you said, clinically they're not intoxicated, they're okay to leave, et cetera, but technically their level was still high. We'll just say it was 120 or 0.12, and they left and something happened. The alcohol level kind of hurts you in that case if something bad happened to them.
Well, I think it'll be used against you, clearly, if something did happen and maybe you were wrong, in your terms of your assessment.
Mm-hmm. Mm-hmm.
So that's why I think it probably puts you in a bit of a box. And so I certainly would not do it routinely in intoxicated patients. And I don't think anybody really does it routinely anymore, because I think that they know the potential risks. I hope they know the potential risks. And to tell you the truth, I don't know whether this has ever come up, but I think if I were a lawyer and my client got hurt when they left the emergency department, and they were clinically intoxicated in the emergency department, I would use that as a strong case.
Mm-hmm. I'm sorry.
I was just going to say, I've had tons of patients where they're chronic alcoholics. They come in, they get their level drawn because they're obtunded, and it was 400, 500, whatever. And then, a couple hours later, who knows what their level is, but it's going to be 200 or something, and they're fine, and they want to go. And after an hour or two of fighting with them and them destroying the department, I'm ready to let them go. I know that their level is whatever it is. It's not normal. And I let them go because they're driving me crazy. I think this is the level they live at. It's more dangerous for me to let them keep dropping. And I made the decision in my head that they're being more disruptive to the department. There's some danger in keeping them there. And I don't think I'm helping anybody else in the department, the nurses, myself, by continuing to kind of try to manage them in the department. And ultimately, I think they're just high risk patients wherever they are, at home, in the department. And I definitely tend to let these patients go when their level is greater than 0.08. Whether that's right or wrong, I don't know. I don't think we have case law to really inform us. I think once they step into the emergency department, they are just legally high risk patients, whichever way you want to cut it. And you own that risk when you sign up for them, and you own it when you discharge them.
When you say let them go,
mm-hmm.
I think you mentioned earlier that you work at a place where they kind of would just walk into the desert. You let them go someplace with a family member or someplace safe, that kind of stuff, right? That's what you're saying.
I probably I get them a ride to go where they want to go. Ideally, there's somebody else there with them. I'm sure that I've let them go home by themselves too, but they don't go out onto the street where I work.
Yeah, I think it's reasonable if you have a relative who's going to pick them up, and they're not going to fall over and hurt themselves when they leave. Yeah, that you definitely have an elevated blood alcohol, so you can always make the case that somebody's going to be compromised. Which I would go back to ask the question about this patient who had the marijuana in their blood level. Is it reasonable to say that a physician can work with marijuana in their bloodstream? Is that related to them potentially making judgment errors or anything like that? Because we don't really, it's not zero, which is what we like. It's positive. We don't have a quantification of it in terms of the blood level necessarily.
Are you relating this to me letting the patient go?
No, I'm wondering what is the risk here? Because doctors, if they had any alcohol in their system and they made a mistake, that would be viewed as maybe one of the reasons that occurred. If you have any marijuana in your bloodstream or your urine, does that mean that you are in any way compromised as a worker? And that would get around all of this stuff about it's illegal and it's at the hospitals don't want to deal with it. After you're hired, you can come to work and have lots of marijuana in your blood stream or your urine. And so I wonder, what are the risks here in terms of being a clinician and being, it's kind of interesting if you had a mistake if you made a mistake at the hospital, it was obvious. And what part of the protocol was for you to get a urine or blood test to see whether you were compromised in any way. It was like, wow, what do you think, Frank, about whether a physician now, they've already been hired, can they go to the hospital with marijuana in their bloodstream?
Well, if they have a positive urine, it just means that they used it in the last 72 hours. But if they had, there's this one active thing that they've looked at, and granted, there's lots of active things, but they looked at Delta 9 THC. And, if that's over 2 nanograms per ml, they usually suggest that they use recently. And recently usually is in the first 4 hours. And they say that impairment doesn't typically last with smoking marijuana, for longer than 4 to 6 hours. I mean, obviously things are variable, and now people eat edibles and stuff like that. But they've done tests, memory tests, motorcycles, swerving, throwing bodies out there. A lot of these things are simulated, so they're not absolutely true to life. But I think if you draw blood tests and you do have Delta 9 THC, I think some people would say that correlates with impairment in these simulated tests. If you have a urine test, I would say it's useless. But I would say the hospital is going to say, well, it might be useless, but it might suggest that you were impaired at some time. We're not going to play that game. So sorry, and I don't think they draw your blood. I think they usually just do a urine test. I don't know. I would ask for a blood test.
Got you.
Yeah.
There are lots of analogous cases you could come up with. I don't have any in front of me, but there are cases where, physicians have operated when they're sleep deprived or have had, drinks the night before. They're not actually drunk, where these things have been brought up. So, these issues have been litigated before, at least to some extent. But back to the discharging drunk patients, you sent a case, Frank, that got some press when it first came out about the discharged drunk patient in New York, which I thought was interesting. And there have been some kind of contrasting cases decided in other states. I don't know if you want to talk about that one.
I don't know why I brought this up. It kind of popped up, but there's the title was great. It said New York's highest court finds ER physician and hospital have no duty to prevent intoxicated patients from leaving the hospital. And the case was Kowalski versus St. Francis Hospital. And I think it was in 2013. And I think the person kind of was intoxicated and the person kind of left. And then something bad happened. I don't know exactly what happened.
He got smoked by a car, I think.
Yeah, I think there was.
Yes, it was very bad.
Died. Yeah,
death. It was bad. Yeah,
pretty bad. Yeah, very bad. So, they argued that the patient was able to walk. He was able to carry on a conversation. But they also write he was unquestionably had a high alcohol level, but was in control of his faculties. It says, obviously written in legal terms here. And the others argued that it would be safer if he went to a detox facility rather than the street. But, you can't force everybody to go to detox, and
his alcohol level is 0.369, by the way.
0.36. Yeah, that's pretty good, right? Or, yeah. What do you think of that case?
So it's interesting. So the New York State Court of Appeals, so that's like their Supreme Court, said that the hospital and emergency physician had no duty to keep him there, that they couldn't hold him against his will because that would be false imprisonment. And so everyone kind of, initially when this came out, they said, we don't have to hold drunk people anymore. If they want to go, we just have to let them go. But I wanted to talk about it because I saw this kind of go around, and that was kind of how it was interpreted by emergency physicians, is like, we're just going to let drunk people go now. But I wanted to put a couple little caveats on that. First of all, it's one state, so every state does its own thing. Second, there was New York has kind of a couple of weird laws. It has this thing called the mental hygiene law. And that basically says that when a drunk person comes into a hospital under their own will, not when they're brought there, but when they come in on their own, if they want to leave on their own, you can't stop them. You shouldn't stop them. Versus if they're brought there by somebody else because like somebody's worried about them or police bring them in or something, then and they try to leave, then you actually like should stop them. And so this guy, he come in with a friend because he wanted to go to detox, and then it was taking so long that he left. And so when the court was interpreting this, they were looking at that mental hygiene law, which applies to people that come in on their own. So they were like protecting his rights under this law because he'd come in on his own. So they were applying that specific law, which is very specific to New York, saying we don't, wrongfully imprison people who come on their own accord. So it was, it would be a very different outcome likely if somebody else had brought him in because they, were worried about him, or the police had brought him in or something. Then it probably would have been the opposite ruling saying, no, absolutely, you should have kept him there. And now you're in lots of trouble for letting him walk out. So very specific to New York, very specific to this mental hygiene law. And also other states that have had essentially the same fact pattern before them have found the exact opposite. So, before you look at this and interpret this as if, I'm just going to let these drunk people go. No.
It's confusing. I don't know how to keep these court things straight. I don't know if you saw that Amtrak case. There was this California jury awarded like this huge Amtrak lawsuit. The guy got like I shouldn't say he got. The award was like $28.6 million. And this guy goes into an ED. The ER doctor sees him, says he's okay, doesn't have to check an alcohol level, and the guy leaves. And I forgot if he just kind of left on his own or he was formally discharged, but the ER doctor just felt like he didn't have to keep him against his advice and et cetera. And then he goes out and lays on a train track, and Amtrak train runs over his legs, and he's a double amputee. And when he wakes up, obviously it's a long hospital course, in court, he doesn't remember anything. I don't remember going to the ER. I was drinking. I don't know if I drank in between the ER and the train station, all of those things. I don't know. But the ER doctor was held liable, I don't know, 30% or, $10 million in that case. Obviously, the big money is Amtrak. And there's videos of this case, if you ever want to Google it. It's dark. And the kid is dressed in all black, and he's sleeping on the train track and he gets his legs cut off, very, very tragic, that scares me too. It's like, should the ER doctor have like forced this guy to stay? Sorry, I'm going to tackle you. I'm going to tie you down, with the chance that he gets battery charges against him. I don't know how often that happens. I mean, you'd probably have a better handle on how often battery charges happen against physicians, but that case really scared me. So I should have given you both cases, one, the New York law, and then this one,
We talked about the Kowalski decision a bunch of times here. And I think that doctors should just do the right thing, because they're not going to know the nuances of the law as Rachel defined it. Certainly not. They're not going to know this bifurcation there. I think you just need to do the right thing. And if you break the law, it's kind of like, well, who's going to fine you, or who is going to fine you that you should be criminal, not put in jail because you broke this law. It's like,
but arguably,
nobody's going to do that.
Arguably, he was doing the right thing. Like, this guy wanted detox. Who knows how long that wait was? Maybe it's a month-long wait for detox. For his.
Well, the right thing was to let him go. And,
well, that's what I'm saying.
And so in that case, it's a bad decision. And the fact, well, in that case, it shouldn't be generalized by any stretch of the imagination. I just think that when this comes up, it's just kind of like, do what's medically right, and a group of your peers will not basically attack you because of this. And frankly, what's the likelihood of you being hauled into court, except for the Kowalski decision? It's like, don't worry about it. Just do the right thing. And forget it.
So you think it was okay that they let him go? That you guys talked about this before?
Yeah, I mean, I think that these are all nuances about how compromised this person was. I agree that I do remember it was somebody who was brought to with his friend, and he was waiting for detox.
Yeah.
And so you don't know how compromised he was necessarily, but I think that this is not extrapolatable to 99.9% of the people who you're going to deal with, you're going to make a decision, are they safe to go home? And you're going to, now that Rachel mentioned it, if you want to bring up the 4 issues of capacity, then go to it. But I think it's largely a clinical judgment.
I think in this case, you're not going to protect yourself much by documenting capacity with this guy and his, maybe you could try document capacity with this guy and a BAC of 0.369 or whatever it was. But I think what you can do is document that you're making the decision because you think it's in the best interest of this patient. And that's going to go a long way, because when we see people get in trouble, it's because they essentially have no documentation. And it looks like they're just trying to get rid of a problem patient. You've got to, put a little time in to say that, to demonstrate, like, if something happens to this guy, you made this decision because you thought it was in the best interest of this guy. You spent some time thinking about him. It wasn't just like, yep, guy's drunk, he wants to leave, I let him go. It's, he is intoxicated, but we have a safe plan for him. I spoke with him.
Right.
This is what he wants. He knows that he's welcome to come back at any point if he changes his mind. I got him a bus ticket. I saw his friend. He was ambulating well. I gave him a sandwich, whatever it was. So it was a person. The future judge, the future jury recognizes that you saw this individual as a person. You cared about him. You cared for him. God forbid if something happens, he was not just somebody you tried to get out of your ED as fast as possible.
That's good. Those are good recommendations for documentation. You have a smart phrase for that, or you just kind of
No, people have heard me talk. No, I'm kind of anti-smart phrase, because I think you can sniff them out, and the more that you can see that that you thought about that particular patient, and there's something in your documentation or throughout your documentation, it's patient specific. I think that's like very apparent to people that are looking at it in the future. And I don't think it takes that much longer,
Yeah. Wow.
Especially with transcription.
Yeah.
Yeah, I think the idea of having these phrases are, obviously they're self-serving, and these little paragraphs. And I think that if it comes out in court that this is a paragraph that has been used in the past, it's identical to in the past. It's like, well, the doctor just pushed a button and blew out this, really covering their butt paragraph, kind of thing. But in fact, you use that all the time, and it wasn't specific for this patient necessarily. I think macros really do have some risk, particularly when we felt compelled to do, have a macro for this standard neuro exam, neuro exam that you've never done in your entire life, kind of thing. And when people put that stuff down, I think it's interesting too. As of January 1st, charting in emergency medicine is changing drastically. There are no more mandates for reviews of systems and 15 of these and this many boxes of that goes away totally with regards to getting paid. It is all based on medical decision making now, very specifically about medical decision making. And history and physical is one that is considered medically appropriate, which is a wonderful thing for emergency physicians. These rules that came up in 1995 regarding documentation are gone. The only thing left is medical decision making, and so that now dictation, I think, will become the primary way to document, because you'll do a paragraph that is a fraction of what you used to do before, perhaps, and it will be customized to this individual patient based on what is wrong with them. And I think that these forced histories and physicals that had all of these elements that, especially I love the box that said all of the systems checked and negative. I mean, that was a lie on freaking every chart that needed 15 of these, you know. The government allowed you to lie. Here's the box. Check that box, okay? So I think, I don't know how many physicians know about this change. I think we should be in some way celebrating big time. And but we do need to learn more specifically now how medical decision-making goes, because that's how you're going to get paid now, strictly on medical decision-making.
I think that's great, right? Because
yeah, absolutely,
anybody could check the boxes, like you said, but I tend to be an under orderer, you know, county hospital teaching. And so let's say I have somebody who I think is intoxicated. I might not get anything on him and just watch him and see how he progresses and document his exam, et cetera. But some of my colleagues will say, well, he's altered, so I'm going to check labs on him. I'm going to check a CT of the head. And if I get a CT of the head, I'm also going to check a neck because I can't rule out a neck injury. I was like, you know, there's not a bump on the guy. And then when you do medical decision-making, then that guy could say, I ruled out hepatic encephalopathy. His liver enzymes are normal. I ruled out anemia causing his coma. You know, he's not anemic or something silly, you know. And I just fear that this sort of medical decision-making is going to lead to more people ordering tests rather than saying, you know, logically, he doesn't have this, doesn't have that. You know, you almost get a high test order sometimes is going to get more money out of the system. I hope not.
No, actually, that's probably not true now.
I'm excited that you say that. Tell me why.
Because there is some element of it related to tests, but not as much as you would think. And tests are counted as like individual. Like if you order a comprehensive metabolic panel, which is like 15 tests or something like that, that's considered one test. Because the test is defined by its CPT number. Anyway, a comprehensive metabolic panel, it's got one number. It is one test. But like a D-dimer is also a unique test, and a troponin is a unique test, and an EKG is a unique test. They all have specific numbers. However, it's not the totality of those numbers in terms of adding them up. It's kind of like that's just one component of the medical decision making, and so there are very specific instructions. And I think, frankly, doctors are going to need to kind of get familiar with those. Yes, they've been relieved of this burden of all of these checkbox oriented kind of things, but they do need to know now a little bit more specifically what the coders are going to be looking for in your chart, so that they are, you know, level 5, level 4, level, those kinds of things. I think it's absolutely wonderful. They've been doing this in primary care now for 2 years. It was an experiment of such, and I think it was also done in urgent care as well. But I have a friend who is the head of CMS for the Southeast region of the country, and I've known him forever and ever. And about 3 or 4 years ago, there was an ASAP meeting in San Diego, and I remember talking to him about what they were going to do or try to do in primary care related to getting rid of all these boxes. And I said, well, what do you think? You know, emergency medicine is kind of like primary care in terms of these boxes. What do you think about emergency medicine? And I remember him saying, to this day, he said, no way was that going to happen in emergency medicine. And yet here, this wonderful relief is upon us. And I think it's terrific. But on the other hand, you need to know about medical decision-making and what will be counted in terms of your ability to level 4, level 5, because it's really fairly specific now. And medical decision-making always had, you know, this issue about data and risk and those kinds of things, but now they've defined it a little bit more specifically, and in some cases it is substantially different than it was in the past. So good things. Yeah. And I think it will allow for better documentation, honestly, because I think that histories and physicals will be more clinically appropriate now, and that will not take a lot, and I think it'll be. I think that those places that have free text dictation will do it. I wonder what effect, if anything, this will have on scribes. I think it potentially will have a big effect on scribes, actually. So big things are happening, and it's happening in 6 weeks.
Wow. Do you think it's going to increase scribes or decrease scribes?
I think it will decrease scribes, honestly, but you have to have free text dictation. And I think, honestly, you always needed free text dictation for medical decision making, which was by far the most important part of the chart, something that doctors really needed to do. I mean, scribes could do the review of systems and all that other stuff, but when it came to, unless you were standing there and they were basically taking your words,
But ultimately, this is just billing for the physician fee schedule, but all of the other services like CTs and everything is separate. So to your question, all of the extra tests aren't affected by this, yeah?
No, they're not affected by it,
Okay.
but their role in terms of determining whether this is level 4 or level 5 is different, because there are equally weighed parts that relate to the risks of the treatment that you're going to be rendering. It set that's one of the things. The amount of data is another thing, and there are 2 or other things which I'm blocking now, but which have become very specific about what you need to do. So I think that free text dictation is going to result in shorter histories and physicals, but maybe more robust medical decision making.
Yeah.
Which is, honestly, what we get paid to do.
But all the over testers will still be rewarded.
No, I don't think so. Honestly, I mean, there's a limit. If you order 15 or 3 or 4, it's kind of like, the data is once you've ordered 2 or 3 or 4, the data becomes, large. So I don't think that if you order 10, it's going to be, you've already exceeded the large. I'm very concerned, honestly, about training programs where residents leave who are just test machines.
Right.
And this issue about, doing an exam with a patient kind of thing, or is de-emphasized, and ordering is emphasized. And I think that I'm very concerned, because I think that that's the trend. So Frankie, I think you may be in the Jerry Hoffman minority, and because people think they're covering their butts when they do these things. And we're teaching residents, and what you're teaching them is to be ordering machines.
Oh yeah. Whatever. In general, a lot of people do it before they see the patient, right? They're in triage, they have abdominal pain. Let me order these labs, these pain meds, it says nausea, let me give them this, without saying hello.
All right. Should we summarize some of the legal points we talked about before you guys get on your testing rant?
No, testing grant's over. I wondered whether, in fact, there were other things, Frank, in your list that that we have skipped over that may have been important. So we covered opioids, we covered marijuana. I think there was a couple of other things on your list.
I think we covered alcohol. I mean, all of these topics could be like 1 hour, I think, in by themselves, excuse me. I think we covered the buprenorphine stuff. We covered a little bit with the alcohol stuff. I think we covered AMA enough, right?
I think so.
And capacity and stuff.
I think we beat that to death, actually.
Okay. And then we covered the pros and cons of getting levels, I think, of alcohol.
Right.
Yeah.
And I think you've been a terrific help in dealing with some of these issues, which, especially, with regard to marijuana, which is really going to come up, I think, very frequently. And Rachel, the case that you brought up is kind of like is scary.
Yeah.
Because I think the hospital did a substantial disservice to this physician by not telling him the rules that they're going to play by. And it sounds.
I wrote down some stuff. You want me to write down some of the stuff we talked about? You guys can disagree with it.
Go ahead.
All right. So don't assume it's okay to use marijuana if when you're moving to a new state, even if it's legal in the state that you're in, that's kind of in reference to that first case we talked about. All right. Don't buy CBD from suspect sources because it's likely to have THC in it and you'll test positive.
Very good point.
Reputable sources only. Then we got some tips for how to beat a marijuana test. Thank you, Frank.
Oh.
Dilute.
So you're likely to be positive for 2 to 3 days, longer if you've got a high percentage of body fat or if you have high frequency use. But
Or
you
edibles.
can dilute your urine, yes, but not too much.
Wow.
Drink some caffeine at the end and then give yourself a day to maybe some Gatorade or something with some electrolytes to beat the test.
I meant to ask at the time, you invalidate your urine if it is too dilute. Is that true, Frank, on these tests?
Absolutely. Yeah. You invalidate it. Yeah. If it's
It doesn't mean that you flunked. It means that you have to take it again or something, or did it mean that you flunked?
I used to do medical review officer work, and that would be a flunk. That would mean if you go so low, it means that you added water to it. But if it's still physiological, it usually means you'll repeat it. And usually they tell you to hang out and wait. So yeah.
In overdose cases where you're needing naloxone, strategy would be to try to wake the patient up slowly with lower doses to avoid getting the patients agitated where they're wanting to leave prematurely. If you get in that situation, consider using Suboxone or buprenorphine to try to mitigate this. And those could be useful in a lot of situations. We're probably underutilizing those. Blood alcohol levels are not necessary, but if you do use them, considering getting follow-up levels to document sobriety, or document sobriety clinically, and just recognize that there is inherent risk in doing that. So, be clear in your chart about discharging those patients.
Can we clarify that point about repeats?
Yeah, throw your 2 cents in.
Did we actually? I don't want to basically give people the idea that maybe you're recommending repeats, but I'm certainly not recommending repeats, because I think that we don't have to show that they are at 0 or some arbitrary number. I think that would be a mistake.
All right, and Frank, what do you do?
No, you usually don't repeat.
Okay.
But we didn't really talk about it, but the range of metabolism is wide. The average person, give or take, is 18 to 20 milligrams per deciliter. So if your level is 100, it takes you per hour. Sorry, if your level is 100, it takes you 5 hours to get to 0. But a lot of people put 35, and that's the rock star. That's the Olympian of drinking. That gets up that high.
Okay.
Yeah.
And for pretty much all these scenarios, when a patient's leaving that's been intoxicated, document capacity, as we talk about over and over here. And the last thing I have written down is come back and do opioids with us.
Oh,
not
that's awesome.
not that do them with us. You know what I mean?
Yeah.
Talk about opioids with us.
Wow, that's awesome. It's such an honor. I'm looking for my cassettes when I go home to see if you can find one of that.
I would like to see a cassette.
She doesn't know what a cassette. What is a
okay.
cassette? No less one of our cassettes.
Rachel, you grew up in the CD era. You know what a CD is?
I know what a cassette is because, they had these things where you could for $1, you could get 15 CDs and they would mail them to you and then they would rip you off if you forgot to send it back or something. My brother convinced me as a mean joke to do cassettes, that they were cool. So I would get the cassette of the month and I had nothing to play it on and he laughed at me every month. So
used to be 8-tracks too.
I don't know what that
on
is.
8-track stuff.
No idea what that is.
God. Anyway, thanks so much, Frank. I really enjoyed it. I think that we would like the opportunity to invite you back
every month. I'm in.
Heck yeah.
This was terrific.
Great.
Thanks so much.